Okay, so the QR code for CE is on the screen. This week, I wanted to talk a little bit about behavioral health challenges. And so we're going to talk a little bit about history and how we got to the point that we did with behavioral health. We'll talk about agitation in behavioral health patients and then kind of management of that. We're actively kind of working on revising the behavioral health protocol. So this has kind of been on my mind a lot. So I am also interested to hear what challenges you guys are facing in the field. I know that these patients can be incredibly challenging, and currently we have some changes happening with law enforcement response to these cases that can make it particularly challenging when you have an agitated patient. So I'm going to talk about that a little bit as well. But I'd love to hear any perspectives that you guys have on this. And if you're not comfortable sharing it on the recording, you can always email me and let me know what's been going on in your agency. Um, so before we do that, just a brief overview of some of our protocol updates that are coming up. I'm sure you guys have already started to review this, but a few different protocols are going live on September 1. First is spinal motion restriction. And I just wanted to emphasize with the spinal motion restriction protocol, the goal is really not to increase use of cervical collars or increase use of backboards or anything along those lines. It's really meant to be applied only in the situations where you've got a patient with blunt trauma who meets any of the criteria listed here. In some ways, I would expect that fewer patients would be immobilized. So some of the differences is that we're not really employing spinal motion restriction just based on mechanism alone. So that's a change. Previously, it had been if you had a patient with severe multi-system trauma, all of those patients would be immobilized. And that's no longer the case. We're really basing it on blunt trauma plus any of these criteria here. And also, one of the things that we're doing is de-emphasizing the use of backboards. And so you'll notice as you read through that protocol that the backboard is really meant to be an extrication device. And, you can immobilize the patient using, or not immobilize, but restrict their movement using a scoop stretcher or a breakaway flat, or even the gurney itself. So I want to be clear that it's not meant to immobilize every drunk person who had a ground level fall, right? So we're really trying to sort of specifically target when we're immobilizing people. So that's coming up. I know that's a big change. And then our pediatric arrest protocol, as well as our neonatal resuscitation protocols, have been updated. In some ways, I think, especially with the neonatal resuscitation, this is just much more simplified. We're not using that 80 to 100 category anymore. There's no more APGAR. We removed dextrose and glucagon from the equation altogether, mainly because that's really a post-arrest kind of intervention. And so that can be done, as soon as feasible. It doesn't have to be done immediately. And then with our pediatric arrest, sort of simplified that, combining those different rhythms into a single protocol. And then we added some drug cards that are length-based to the protocol as well. So that's coming up. What's coming soon? This is something that's been in the works for a while. We are moving towards having BLS eye gels added to the scope. This is an optional scope, so it will be up to individual agencies whether they choose to employ this. And there are specific state regulations around how much training has to occur. It's a pretty extensive training. But we are going to add that eventually. That's coming up, and then pediatric eye gels will be added as well. And then we're updating the behavioral health protocol, which is kind of part of why I'm talking about this today. It's been kind of a topic of discussion and something that's been on my mind quite a bit. And then our allergic reaction and anaphylaxis protocols are being updated as well. So that's going to be kind of our next cycle. There may be one or two other things. I'm trying to add in some of the easy stuff as we go, but so that's kind of what's next. So um, so forgive me, this is sort of ridiculous, but we're not talking about acute behavioral disturbances here. This is a very cute little behavioral disturbance. This is my puppy when she was like 3 months old and was actually a nightmare. Um, Rather, we're going to be talking about acute behavioral disturbances. So um, we're going to start with a case. This is just sort of a thought exercise, really. So this is a male in his 20s. He's in his car at a gas station having spasms at 2 a.m. When you arrive, the patient's confused, sitting in the front seat of the car, making animal-like noises. The boyfriend reports that he's been using meth and there is a knife in the car. Can't obtain vitals. The patient's agitated, hot, diaphoretic, and attempting to strangle himself on the seatbelt. So, I mean, this is probably something that y'all see very often, similar situations, right? We have a lot of meth in this town and a lot of agitated patients. So, what are our options in this situation? So, we can contact law enforcement for assistance, right? We've got a patient with a knife, he's agitated. We can attempt to physically restrain the patient ourselves. We can try to give him some intranasal or intramuscular midazolam, although I'm not sure that will be the safest option in an agitated patient. We can remove ourselves from the scene, leave the scene, it's not safe, or we can contact base for guidance. And I think this is a difficult situation. In this case, you try to contact law enforcement and say, hey, I've got, this is my situation. I need some help with restraining the patient. And they say, we are not responding. And so there has been a little bit of a shift, and maybe this is not such a recent shift, but there are some agencies, and this is happening across the country and across the state, that are declining to respond to behavioral health calls. And I, a little bit naively, did not think this was really happening in our region, or at least not happening very often. And it's recently come to my attention that this actually is happening and not infrequently, where law enforcement says we are sort of disengaging on behavioral health calls because the crime is not being committed. And so I want to talk a little bit about the background of sort of why this has started to come up more and more, why this is happening. This is a issue that is occurring all over the country and the state. Um, and so back in earlier this year, Sacramento County Sheriff's Department very publicly came out and said they are not responding to behavioral health calls. They will only respond if there is a crime being committed and there's a danger to the public. So if a patient is trying to kill themselves, if a patient is agitated, or even if they're violent, if a crime is not being committed, they will not be responding. And so while they are one of the few agencies, I don't think very many have come forward so publicly to state that they won't be responding. There are quite a few agencies across the state and even across the country who this is their policy and it's just not expressly stated. And so I want to just give a little background on why this has developed the way that it did. So this has actually been something that has been developing over a number of years. This is probably dating back to the early 2000s, based on some cases where there were bad outcomes in patient and behavioral health calls at the intersection of mental health and law enforcement. And so most recently, though, there was a case that made it to the Ninth Circuit. This in 2019 is when this incident first occurred. And so two police officers responded to a patient who was in behavioral health crisis in Las Vegas. He was schizophrenic and paranoid. And he was in his apartment and thought people were outside trying to get him. So very, very paranoid. The officers respond to the scene, eventually got the patient to come out of the house and basically asked him to give over any weapons that he had. He did and willingly handed over a knife and a metal pipe. But given that he had had weapons and was so paranoid, the officers didn't feel comfortable taking him into custody without having him handcuffed. The patient was so paranoid that he refused to be handcuffed. He said, I can't turn my back to you. I'm scared that someone's going to come get me. And ultimately, the officers attempted to take him into custody. There was a physical struggle. The patient was prone and had the officer's body weight on him for about 95 seconds, so not very long at all. 95 seconds of compression body weight restraint, and he subsequently went into cardiac arrest. So the patient ended up dying, and they weren't able to revive him. And the patient's family sued the law enforcement officers. And the Ninth Circuit Court, in a ruling, I think early or maybe late 2024 is when this came out, decided that the officers did not have qualified immunity in this case. And so qualified immunity is what protects the officers if someone is injured in the process of taking them into custody. And so they said, you're liable for this person's death. You used excessive force, and those officers lost qualified immunity. And so this has been cited repeatedly as, the officers do not feel like they are protected in responding to these calls anymore. And part of the ruling was that, the person wasn't committing a crime, so they had no right to take him into custody. And so This is a big deal, and this has been cited repeatedly as sort of the reason for not responding. But it goes back further than that. This goes back to many years ago. This is a still from the the body camera footage where basically, the officer is trying to restrain the patient. He has a knee on his chest, and that ultimately is, not considered to be an appropriate restraint technique and can lead to asphyxia, and in this case, apparently did. So, but this dates back a long way. And so part of what I'm going to talk about today is this entity of acute behavioral disturbance with agitation. It's also referred to as hyperactive delirium with severe agitation. But back in the day, this used to be called excited delirium. Excited delirium is a dirty word now. Nobody uses it. It's like it's been removed from all medical literature. Part of it is because there was so much controversy around this. There was all of these deaths that were occurring in police custody, and they were chalking it up to this idea of excited delirium. But this is what really a lot of these cases sort of um, began to trigger this lack of response. And, it is a difficult situation, right? Because um, sometimes law enforcement's presence on scene at these behavioral health calls just escalates things. But there are times when you've got a violent patient that you do need to bring into custody, and how do we navigate that intersection? And to be honest, I don't think anybody really knows. And so we're at this really difficult crossroads right now of trying to figure out how do we get people the care that they need when we don't have that
It
additional
says 10, so I'm assuming
our
that the
law
10,
enforcement.
all of that is probably the point number.
Sorry, I'm going to mute whoever that is.
Colon stuff.
So, and I think in California, this is particularly problematic because of some of the legislation that we have around behavioral health. And so in California, we have this legislation called the Lanterman-Petrus Short Act of 1967. And this was a really actually well-intentioned piece of legislation. So back in the 50s, a lot of people were committed to lifelong involuntary psychiatric commitment without due process. So they would go for like a 5-minute hearing and they would say, you're institutionalized for life. And so that was happening repeatedly. And we had these big state mental hospitals that were filled with thousands of patients with mental illness, and they were just forever institutionalized. And so this act really was part of the driver was this to restore civil rights to people with mental health issues and give them due process. And so the intent was good, but unfortunately, while they removed that institutionalization, they didn't replace it with anything else. And so they shifted the care for these patients from the state institutions to the local government. But there was no requirement or funding for local governments to care for these people. And so what has resulted is what we see now, which is, this homeless crisis with people with severe mental illness who cannot get into care and are just on the street. There's huge issues with substance use. And, a lot of it sort of circles back to this well-intentioned act. So, um, and another thing that came out of that was this 5150 hold, this 72-hour hold. This is unique to California, although other states have statutes that require police to be involved in placing patients on behavioral health holds. Ours, either a police officer or a designated mental health professional are the only individuals who can place a 5150. That being said, each individual county can designate other people. There are LEMSAs who have designated some specific crisis unit paramedics to place 5150 holds. So that can occur with the blessing of the county behavioral health people. And then, we all know the criteria: danger to self, danger to others, gravely disabled. And what gravely disabled is referring to is somebody with severe mental illness or substance use disorder who can't care for their basic needs like food, shelter, medical care, personal safety. And I think that thing to emphasize is that it is meant to be for patients with mental illness or severe substance use disorder. It's not for patients with dementia. It's not for patients who are just making bad decisions. It's not for, patients who are making bad choices for another reason. And I think that gets a little misconstrued sometimes. But so that's where things stand. And it's difficult for us, right? Because while police officers are generally in the field, the ones who are placing a 5150, now they're saying, well, we're going to disengage with restraining these patients or responding to these calls. And I'll say that this is not universal, right? There's a huge amount of variability between different law enforcement agencies on how they're responding to these calls. And you probably have more insight into what's happening out there than I do, as far as which agencies will respond and which won't, and which calls they will respond to. But we're kind of reaching a point where this is becoming a problem. This is a challenge that I don't think anybody out there really knows what to do with. When it comes to how to respond to this, so if you look at what Sacramento has done, they have implemented a disengagement policy for EMS for those patients that are violent and agitated. So if law enforcement is not responding, and EMS is on scene and they cannot safely take care of the patient because they're too violent or too agitated. They get the EMS supervisor involved, they get the law enforcement supervisor involved. Those two talk to each other and try to come up with a solution so that that patient can safely get to care. And if law enforcement is still not going to respond, then EMS can disengage after 30 minutes with careful documentation and some very specific outlined steps. So that has been their response to this. We are beginning some discussions about how to respond to this as well. And so I am really interested to hear perspectives from you all as providers on what you think would be best, because this is a tricky situation and we want to make sure that everybody's safe. So a couple of other legal issues dealing with agitated patients. We've talked about capacity determination on this Tuesday series before when we talked about RMCTs. But I'm going to talk about that a little bit more. There's a duty to protect, and battery and false imprisonment are some of the issues that come up with these cases, among others. But when we talk about decisional capacity, and I've said this in the past, it's really more than orientation. And I think it can be easy to think, okay, this person is alert and oriented, they're GCS 15, they have capacity, but that's not always the case. Capacity really requires that a person is capable of understanding the nature of their condition. Are they capable of understanding the risks of what not going to the hospital entails? Do they have insight into the severity of their illness and what's going on with them? If not, they may not have capacity. And I think the assessment of capacity is one of the situations where the base hospital physician can be helpful, but that's only helpful to the extent that you can get the patient to come to the phone, or you can get the patient to engage with you and talk with you. And so sometimes you have to base that decisional capacity on the behaviors that the patient is exhibiting as well, right? If they are doing something that's clearly not, safe, then that could be a sign that they don't have capacity. But I think the base hospital physician can help make this determination, and this is often very nuanced. So getting them involved, and I hope that they will come to the phone and help you through this discussion, because that is the idea behind the base hospital physician. I realize that sometimes they're not always as helpful as we would hope, but that's the idea. So duty to protect, and this is the idea that once you have determined that a patient doesn't have capacity and you are going to treat them under the idea of implied consent and treat them sort of without their consent, you have a fiduciary responsibility to that patient. And fiduciary responsibility is really meaning that you are responsible for the health and welfare of that patient. It's like a parent or a guardian sort of situation. You are taking responsibility for their health and welfare. And so there was a legal case that kind of exemplified this. So the case was there was a 32-year-old patient who was threatening to kill his psychiatrist. He ended up getting chemically and physically restrained, but was not appropriately monitored. So they basically strapped him on a backboard, flipped him upside down in a prone position, put a towel over his head to keep down the stimulus. And somebody looked over and noticed that the patient's hand was sticking out and that it was blue, and the patient was dead. And so, of course, the patient's family sued and won. And basically, what came out of that is that restrained patients require frequent reassessment and appropriate monitoring, right? Because we have a responsibility for their health and welfare once we restrain them. Battery and false imprisonment, this is also tricky situations, right? So this is where that idea of capacity becomes very important. And so battery is that intentional infliction of harmful or offensive bodily contact that could be restraining a patient against their will when they have capacity to refuse treatment. And so the case in this situation was a patient who had chest pain. He was at work. His supervisor called EMS, even though the patient didn't have insurance and did not want EMS to be called. The supervisor had said over the phone to dispatch that the patient was sort of not quite right, and he was a little bit slow and repetitive in his responses, but not clearly documented as being like confused or disoriented, just not quite right. The patient was ultimately declining to go. He said, I don't want to go to the hospital. PD ended up getting involved in that case and put the patient on a hold, which is required in the state where this occurred. Um, and he was transported to the hospital in restraints, got his full medical workup, ended up being cleared and discharged. And then he sued and won because he said this was battery and I was taken against my will, and the courts agreed. And so I think this just highlights the importance of really good documentation and making sure that your assessment of capacity is appropriate. Um, False imprisonment, this is again in a similar vein, that idea that you are intentionally confining a patient against their will. And so there was a case where a patient was agitated and making some like vague suicidal statements. They ended up going into the ER. They were not initially placed on a hold, but began hitting their head against a wall. Definitely inappropriate actions by the patient. They were erratic. They ended up leaving the hospital in like it was somewhere where it was cold in the middle of winter, wearing only a hospital gown. They ended up being brought back to the hospital and at that time were placed on a hold, but they didn't, in the state where this occurred, it required some specific paperwork to be filled out, and that was not done. So the patient was placed on a hold without the appropriate paperwork. And even though they clearly were not appropriate and should have been on a hold because they didn't do the paperwork, the patient sued and they won. So this just highlights the importance of following appropriate protocols. We cannot, as EMS, we cannot put a patient on a 5150 and we cannot force them to go for mental health issues if they are declining transport, right? So, and we'll talk about implied consent next. So this is the idea that we can take a patient to the hospital without their consent if the following are true. There is an emergency medical condition. Um, we can't get consent either because they clearly don't have capacity or because they are incapacitated or unconscious. What we're doing for the patient is for the benefit of the patient. And so, my threshold for this when I am assessing capacity in a patient, if they clearly don't have capacity, um, I have to weigh, is the risk of putting them into restraints and forcing them to go to the hospital outweigh, like you're basically weighing the risk of taking away that patient's freedom with the risk of some bad outcome. We don't always know that, but I try to consider that, right? If it's a stub toe, obviously we're not going to make them come in. Um, so we do have that option in some situations, but when it comes to psychiatric complaints, there's very specific laws around that. And so where the base hospital physician fits in this situation, like I mentioned before, I think they can be helpful in determination of capacity. They can be helpful in convincing patients to come in some situations. Now, when you've got a super agitated patient, that might not really be the case, right? Because they aren't going to come to the phone and they aren't going to talk to anybody. So it may not be helpful in those situations. They can be helpful though if you need additional sedative doses, for instance, right? They can be helpful in that case. But what they can't do is compel you to restrain a patient or deny an RMCT. And so as we are revising our behavioral health protocols, one of the things I'm hoping to do is sort of remove the base hospital physician from this equation, only because we've seen so many cases where the base hospital physician says, well, I deny this RMCT, you have to make them come to the hospital. And if you've got an agitated patient, right, that creates a dangerous situation for the providers. And I don't see a benefit for having them provide direction in that case. So we're trying to come up with a solution where, we can sort of remove them from the equation. If you think they'll be helpful, great, but we don't want them to be denying RMCT and trying to compel you to restrain a patient. Okay. Any questions or comments so far? I don't see anything in the chat. Okay, so I want to spend just a little bit of time talking about this clinical entity that is previously was referred to as excited delirium. Now, the more accepted terminology is hyperactive delirium syndrome with severe agitation or acute behavioral disturbance with severe agitation. But it's really all the same clinical entity, it's just got a different name. And this is really just an umbrella term. It encompasses a spectrum of behaviors and vital sign abnormalities that include, sympathetic overdrive, agitation, altered mental status. And then you've got vital sign derangements like hyperthermia, tachypnea, tachycardia, along with metabolic derangements. And so we'll talk about what this clinical entity is and sort of the pathogenesis behind it. There's a lot of things on the differential for this that are bad medical issues. A lot of them are toxic overdoses, so things like serotonin syndrome, neuroleptic malignant syndrome, which is a reaction to antipsychotic medications, anticholinergic toxicity, obviously methamphetamine abuse, and then head injury, among other things. So lots of bad things on this differential. So again, while this is often chalked up to substance use and psychiatric disorders, there's a lot of other bad stuff that can look very similar. And this clinical syndrome was first diagnosed back actually in the late 1800s, and it was published in this journal article by I think it was Lucas Bell was the physician. Oh, Luther Bell, sorry. And basically he described this syndrome in institutionalized patients, and what he saw was that these patients became acutely agitated and got this syndrome called acute exhaustive mania with a very high fatality rate. And so this is thought to be the sort of first description of this entity. And it wasn't really in the literature a whole lot after this until cocaine came on the scene. And so you started seeing these case reports of this drug-induced psychosis and sudden death in patients using recreational drugs. These case reports came about with patients using LSD, with patients using PCP, cocaine, meth. And what you were seeing was that these patients all had sort of a similar constellation of symptoms. Oftentimes, law enforcement became involved and there was a physical struggle followed by sudden death. And when they did a post-mortem on these patients, they found that the levels of cocaine in their bloodstream were actually recreational levels and not what you would expect for an overdose. So it was surmised that there was something else going on here that was not just cocaine intoxication that caused their death. I just want to say about that one. Yeah. Okay. So in the early 2000s, American College of Emergency Physicians put out this white paper on excited delirium. They have since sort of denounced the term excited delirium and do not endorse that term anymore, but the clinical syndrome still remains the same. And so these are some of the symptoms that are described. Severe agitation, hyperthermia, tachypnea. Patients will have unusual pain tolerance. Either naked or inappropriate dressing are a common feature. They have unusual strength, diaphoresis. Keening is kind of this bizarre animal-like noises that sometimes people make. So a whole sort of spectrum. This is from a bunch of different case reports and studies that were talking about this clinical entity. And they also described the characteristics of the patients who are described with this syndrome. And so very heavily weighted toward male patients of a younger age. Substance use is common and psychiatric illness is common. And then the risk factors for fatal outcomes are 100% of the time there is a violent struggle that precedes death. And we'll talk about why that is in the pathogenesis. Stimulant use is very common. Obesity is also quite common. And then patients who are restrained in the prone position, this is a common finding in patients who die, and that's probably because there is some component of positional asphyxia with this. And then hyperthermia is also a risk factor for a fatal outcome. So, how do people die? What does this look like? So, typically, there is a patient, there's a call for an agitated patient, there is a violent struggle in attempting to restrain the patient, and then the struggling stops. And that patient will have shallow or labored respiration followed by cardiac arrest. And so, when you think about the pathogenesis of this, it kind of makes sense. And so, what happens, this is the proposed pathogenesis, is that these patients in their agitated state develop a severe metabolic acidosis. They're sympathomimetic, they're very acidotic, they're breaking down their muscle, they're agitated and hyperthermic. There is an intense struggle, release sympathetic hormones. This increases myocardial oxygen demand, which predisposes them to arrhythmia. So already they're in the state of metabolic acidosis. Their heart is working really hard. And then on top of that, the patient is, somebody attempts to restrain the patient, and there's some element of positional asphyxia. And if you think about what's happening when you're acidotic, what does your body do to try to blow off that carbon dioxide, right? You hyperventilate. And so if you have a really acidotic patient and then you take away their ability to compensate with their respiratory system, they will go into arrest, right? We see this with patients with DKA. And so it's a similar pathophysiology to that in that we are taking away their ability to compensate for that metabolic acidosis, and then that precipitates a cardiac arrest and arrhythmia. They just crump. There also may be some element of stress cardiomyopathy, again, because of that increased myocardial oxygen demand. And so, this diagnosis is actually very controversial and not widely accepted. But if we as EMS people and as emergency medicine people know that this exists, right? Because, and you can kind of understand when you think about the pathophysiology of it, right? So, this is, maybe not the diagnosis of excited delirium, but hyperactive delirium with severe agitation is accepted by the American College of Emergency Physicians and the National Association of Medical Examiners, but a lot of other professional organizations do not accept this diagnosis. There's really not standardized diagnostic criteria. And again, the pathogenesis is theoretical. Autopsies don't really show us anything, so it's not 100% clear why this occurs. But we do know that this agitation is a risk factor for death. And so there's no diagnosis included in psychiatric manuals or in our ICD-10, which is what we use to give diagnosis codes to patients in the hospital. Okay. Let me just check our time here. I tried to pack in. Okay, we're getting through it. The National Association of EMS Physicians has put forth some guidelines around the care of agitated patients in the pre-hospital setting. And I think this is really helpful. And I often turn to this organization and others like it when it comes to thinking about how to, frame these guidelines, because there's a lot of evidence behind it. And also, I think when these cases are super high risk as far as liability and as far as risk to the patient. And so having some evidence-based guidelines, I think, is important and helpful. And so this is some of the things that they recommend. This is from that paper here. This QR code will take you to all of the specifics of these guidelines, but these are just some of the highlights. And so they do recommend considering use of an objective agitation scale. And that's partially to protect patients so that we are not using sedation or restraint when it's not necessary, but also it's to help protect providers so that there is an objective documentation of what was going on with that patient that required restraint. Of course, they recommend treating underlying medical condition, that's a given. Maintaining the dignity of the patient and using the least restraint possible, I think that's also pretty much a given that everybody is aware of. They are very specific about some of the types of restraints that should and should not be used and prohibited techniques, which I'll briefly touch upon. They talk a little bit about pharmacologic management. That's going to be very dependent on the system that you're in, but we'll talk about that a little bit as well. As far as indications for restraint, medication should only be given to protect the patient and others. But sometimes, if we end up having to put a patient into physical restraints, oftentimes that goes along with sedation, only because you don't want a patient who is struggling endlessly against the restraints. That's a possibility that they're going to harm themselves. And so oftentimes those patients do need sedation. And then they are very specific in stating that we should never give medications to assist law enforcement with arrest. And this is because there were a number of cases where EMS providers were compelled by law enforcement to give specifically ketamine to patients to assist with taking them into custody. And there was at least one death in custody, but there may have been other bad outcomes. And this prompted a big shift and definite recommendations that we are never giving this to assist law enforcement. I don't think that is something that we are really doing in our area. And I think that's pretty clear. But They are very specific about that. And then always using the least restrictive method possible, obviously. So some of the just general management sort of recommendations. Verbal de-escalation is always our first option. And obviously, in some cases, that is just not an option. If you've got somebody who is severely agitated and violent, they probably are not going to respond, but it's worth a try, only to the extent that you keep yourself safe. There are some specifics around do's and don'ts of physical restraint. And then when it comes to sedation and chemical restraint, there's really not any clear guidelines about which agent or dose is best. They do, there are some recommendations out there and generally followed guidelines around doses of midazolam and then ketamine. And we'll talk about ketamine controversy in just a little bit. So verbal de-escalation, I'm curious, like, do you guys have, what is your kind of training or background, or what kind of de-escalation training do you get in your classes and paramedic training and EMT training? Do you guys get much of this at all? I know that I didn't, and I also deal with quite a few agitated patients in my daily work. I don't think I ever got any training around this, to be honest. But I think this is an important skill for everybody. And there are some practices and tenets in here that I think are actually useful for just everyday practice with every patient that you see. And it's just general communication guidelines. This is something that, we could spend a lot of time talking about. And probably an entire hour going over, but I'm going to try to hit some of the highlights. I really like this paper. This is from like a psychiatry work group and talking about best practices for de-escalation in agitated patients. I think there's some helpful cues in here. Not all of it is necessarily applicable to the EMS setting, but there is a lot of good stuff in here. So I'm going to hit a few of the highlights. Again, this is not like a all-inclusive talk, but there are some things that I think are helpful to keep in mind. And so, first of all, is just helping the patient calm themselves. And so, I'll talk about kind of a verbal de-escalation loop and what that looks like. But, trying to help the patient calm themselves with that verbal de-escalation loop is helpful. And then, probably one of the biggest things, and I think this is a good practice just every day with every patient, is just don't get defensive. Because, oftentimes patients are rude or they can say things that are offensive, and a lot of times that's a defense mechanism, and so if you can just let that sort of run over you like water, just be water, let it go around you, let it go through you, you'll have a lot better reaction in the end. And this is hard to do, really hard to do sometimes. And so I think this is one where people are rude all the time, and so just trying to get in that mode of not getting defensive about it and not taking things personally is probably one of the biggest ways, because that comes out in your tone of voice, and tone of voice, body language, all is kind of the biggest part of what people perceive about what you're communicating to them. And then another thing that's always good to do just in your everyday practice is try to have a positive regard for the person, even if they're like super annoying or rude. And it is super hard to do sometimes, but sometimes, so this is something that I try to do sometimes if I'm like, oh my God, this person's driving me crazy, is I will imagine them as a child. And so I think about like, what were they like as a baby? And then I can try to be a little more empathetic and step back and be like, okay, just try not to take things personally and try to just have a positive regard for that person in general. And again, we deal with difficult patients and people every single day. And so practicing this in your daily work will be helpful when you have that truly agitated patient who needs to be de-escalated. And then the verbal de-escalation group, the paper that I shared earlier does a little bit better job of describing this, but I'm going to try to give you an idea of what this looks like. So basically it involves just listening to the patient first of all. So what are they saying and what can you take away from that to try to, leverage some way to help them get control of themselves. And so part of the goal of this is just giving control back to the patient, helping them calm themselves down, and being that calm voice. And so I think this is also good to practice just in daily life, is this like we have to perform little Jedi mind tricks on people sometimes, right? And this is a skill that takes time to develop. So practicing it in your everyday life when you've got somebody who just doesn't want to do whatever, trying to listen to what their concerns are, find a way to respond that validates the patient and what their position is, and then state what you want them to do. And you just kind of do that in a repetitive loop. So the example here is you've got a patient that was just assaulted, got a big lac on his head. He's screaming at anybody that tries to come near him. If you actually listen to what the patient is saying, he's upset because his dog is gone. And nobody is getting that that is what is upsetting him. And so you can say, wow, I totally get it. I would be so upset and so freaked out if my dog ran away. Let me figure out how we can help you. I'm worried about your head injury and I want you to be able to take care of your dog in the future. Whatever the situation is, finding a way that says, I hear you and validates it and then, says what you're worried about and try to incorporate what you want them to do. And then you have to do that kind of over and over. And eventually, if the patient feels heard and feels more in control, sometimes that can help de-escalate things a little bit. I'm just going to take a look at the comments here. Okay, so yes. Okay, good. So yeah, some of the comments here are just talking about what people have practiced in their training and yeah, always the goal is to de-escalate the patient. Good. I'm glad that you guys are getting some of that training. Body language is actually, there have been studies looking at sort of when you say something verbally versus how your body language and your tone of voice is perceived can be very different, right? If you're screaming at somebody to calm down, the message is not there. And so body language and tone of voice account for a huge proportion of what message is received. And so this is a really great case. This was like a viral YouTube video. I don't know when this initially came out, but this was an officer in North Carolina who was responding to, it was an autistic teenager who was suicidal. And, this could have gone really poorly, right? He could have approached the patient in an agitated way and escalated the situation, but instead he got down to the patient's level, had his hands in his lap. You can see that he's actually off to the side of the patient. So not directly facing the patient, but just off to the side is a little less threatening. And really just approached it with a caring attitude, and that was reflected in his body language. And so patients perceive all of that, right? And so trying to calm yourself down is probably the first step, and being kind and just actually caring about the patient and having positive regard will be reflected in your body language. So um, some sort of body language guidelines in general, though, obviously hands visible, not clench. Clench hands mean agitation. Stand at an angle or to the side of the patient if possible. Avoid direct eye contact. Try to keep a calm facial expression, and then really reflecting your tone of voice is also important. And these are just some general communication guidelines that are also outlined in that paper, but respecting people's personal space is important. So don't get in their face, obviously. Try not to be provocative. I think that we've all witnessed either our partners at work or other coworkers who maybe are not very good at this, and they get really agitated with patients, and you're like, you are just making this so much worse. Like I sometimes see this at work and I'm like, if you just like weren't provocative with that person, this would have gone a very different way. So really trying not to be provocative. And this is in our current behavioral health protocol, but only one person, if possible, should verbally contact the patient, just because multiple people speaking at once can be confusing. Be polite and just be human, right? I think you can go a long way with somebody if you just validate their position, talk to them like a human being, and be nice. Obviously, that doesn't always work. There are situations where verbal de-escalation just isn't possible, but being concise, keeping the message simple, trying to give them power and control back whenever possible also is really helpful. Okay, that's all I have about verbal de-escalation. There's probably a ton more that could be said. And then a question here, is there a discussion about a certification for a behavioral medic type of role? A certification for medics that can respond to complicated behavioral calls and assist with de-escalation, help manage combative patients or write holds on calls where mental health clinician isn't already writing the hold. So I would love if we had some sort of behavioral health crisis response team that was, I know we have some crisis teams out there, but that was really agency based. From a county perspective, I don't know that we can sort of I don't think we have the funding to start a unit like that, to be honest. But I think that is worth a discussion, and there are places that have done it really, really well. very well. And I think it actually is really successful. And I think as this behavioral health challenges that we have evolve, that is the way of the future. I think that is ultimately what is going, there's always going to be agitated or violent patients where it's not safe to enter the scene. But I think there is really a big role in a lot of cases for those types of folks who have that kind of training and who can administer medications to these patients who can kind of de-escalate the situation and have specialized training. So I would love to see that happen. I don't know how that will evolve, but I mean, that has evolved in a lot of places. And I would love it if we could have something like that here eventually. But it is a big, obviously, commitment of resources for sure. But I think that's a great question and probably the way of the future. So as far as do's and don'ts for physical restraints, I think you guys probably get a decent amount of training on this, so I won't harp on this, but we are gonna, as we update the behavioral health protocol, be a little more prescriptive and specific about do's and don'ts, just for everybody's sort of clarity and protection. Keyless restraints that are easily removed are preferred. That's obviously in case the patient has a change in status and you need to access their airway or whatever really quickly. If a key is required, the key has to be with the patient during transport. And that is specifically referring to patients who are in handcuffs.
And then you
Um,
transfer over to
and we
helicopter.
are
And if you have
going
a
to
medic
include
and
part of the protocol that, if a patient is in handcuffs, the person who can remove those handcuffs needs to be with the patient in the cab of the ambulance, in the back of the ambulance. They can't be following in a police car. Either they need to be changed to EMS restraints or they need to be in the back with the patient so the handcuffs can be removed, and that's for the safety of the patients. Okay. There are some very specific don'ts with physical restraints. I think everybody knows that prone positioning is definitely not okay. Hog tying is definitely not okay. I think that just goes without saying. But anything that constricts the neck, chest, or airway is not as a no-go. And then, I remember back when I was an EMT, this was a long, long time ago. This was the thing that people did. They sandwiched people between two backboards. I remember that. And obviously that's not okay anymore, right? So there were some things that were practiced back in the day that are no longer practiced because we know it's not safe. We know that's how people die. And then no handcuffs or zip ties. So basically rigid restraints are, hopefully you can restrain them in a way that is not one of those methods. Definitely no zip ties. Okay, I'm just make sure there's no questions or comments about any of that. Okay, and then when it comes to chemical restraint, there are a few options. This is just a table kind of showing the recommended dose, the onset of action of different agents. You can see that midazolam takes a while to kick in. And this is probably the most commonly used agent. It's the one that we use. Ketamine is on this list. In the state of California, it's really added to the scope of practice for pain specifically. There are a lot of places where ketamine is used for severe agitation. It has become a very controversial drug in that regard because there have been multiple instances of deaths related to not necessarily to ketamine use. I think a lot of it was inappropriate monitoring and inappropriate use of ketamine. But if you look at head-to-head midazolam versus ketamine as far as complication rates, there is a higher incidence of intubation with the use of ketamine for sedation in agitated patients. Probably that's because ketamine causes a lot of dissociation and people are not comfortable with that. It's not that the patient necessarily stopped breathing in those instances, but the level of dissociation is such that people feel like that person can't protect their airway and they end up getting intubated quite a bit more frequently than patients do with midazolam. So that is a complication and that's not great for patients. But by and large, a lot of places do use ketamine and it is generally considered safe, but it is really controversial in some places and it's a little bit of a hot button issue because of some deaths that occurred around ketamine use. And there, was a case where a patient was administered ketamine and inappropriately monitored, and the paramedics were actually held liable for that person's death. So this is like a controversial drug. It's very hot button in that regard, and some places have moved away from the use of ketamine for that reason. Here we have midazolam. I know our dose in behavioral health, I think the max is 4 milligrams. So we're looking at potentially increasing that dose a little bit, but Realize that part of the issue with midazolam and why you might not see it be super effective is that it just takes a long time to start working. And so for IM midazolam, the onset or peak action is going to be around 15 minutes. And for IN, your peak action is going to be around 10. So you might start to see some effects earlier than that, but it takes a while for it to reach its peak. So, the main adverse reaction here is respiratory depression. But for intranasal and intramuscular at a 5 mg dose, generally pretty safe. You don't really see a lot of severe respiratory depression with that. And then this was a study that just looked at the use of midazolam for behavioral health emergencies. And most of the patients in this study got 5 mg, and they saw improvement in agitation in about 3/4 of cases. In about 25% of cases, it didn't work at all. And I think that probably is reflected in your experience. Sometimes it takes more. And so recognizing that, and I think the key is that just making sure that you have given it adequate time to have an effect. And I know that's hard when you've got a really agitated patient who's aggressive. In this study, only one patient required intubation, and that was at ED arrival, and they didn't see any difference in effectiveness between intranasal or intramuscular. So that is the broad strokes of what I wanted to talk about today with behavioral health stuff. Like I said before, we are kind of at a crossroads right now. And I think with mental health and law enforcement and EMS, we're sort of at a point where everybody is trying to figure out what to do about this issue. And I think it's unclear. It's still unclear. So we're trying to figure out goal is I want to make sure that we have guidelines that support you all and help you feel safe in providing care. And I don't want you to feel like you have to restrain somebody who is agitated. I don't want you to put yourselves in harm's way. And so I want to have policies that support that and make sure that you all are safe and able to do your job and disengage when it's appropriate. That's all I have for today. I don't know if you guys if anybody has any thoughts or comments about anything. I'm going to stop recording for now in case anybody wants to speak up off the recording. And before I hop off of here, I am going to be out of the country next month for Tuesday series. So I'm trying to find a replacement. I have not yet found anybody. So depending on whether anybody is willing to step up, we may have to cancel next month, but I will not be here. So I will let you know in advance if we haven't found anybody. Then I'm going to stop recording.